Hello, everyone. Welcome back. Before we start with the speaker, I'd like to introduce her. It's very quick so that you can listen to her talk. She's a consultant nephrologist based at Manchester University Hospital, NHS Foundation Trust. She's also a postgraduate associate dean at Health Education England, director for conduct and progress at the University of Liverpool, and a vice president global for the Royal College of Physicians in London. She graduated from the University of Manchester, United Kingdom, with a Bachelor of Medicine and Bachelor of Surgery with honors degree in 1996. Dr. Patel is the regional lead for vasculitis and lupus service in the northwest of England. She is currently leading national work on differential attainment and assessment. Friends, ladies and gentlemen, let's welcome Dr. Mumtaz Patel. Doctor?
Thank you, Dr. Amy. That's very kind of you.
Yes.
Good, nice to see everyone. I'm just going to share my screen and put my slides up, if I may. Just give me a second. Dr. Amy, you can see that okay, I hope?
Okay. Yeah. Yes, doctor.
Wonderful. Thank you so much. So thank you, Dr. Amy, and thank you to the organisers for inviting me today to talk about a project and some work that I'm very passionate about. And I'm going to talk about global women health leaders unleashing their potential. I'm going to go through the intended learning outcomes for the talk. So my talk is planned for about 20 minutes. So I will aim to go through in that time. And my aim is to raise awareness of the research and the scale of the challenge around the gender leadership gap globally, to understand some of the barriers, particularly also including intersectionality and how they impact women into entering senior leadership positions, and then provide a framework of potential early interventions to narrow the gender leadership gap and improve outcomes. So what's the scale of the challenge? So we know that women make up to 70% of the global health workforce, but only 25% hold senior leadership positions. That's in high-income countries like the UK, America, but this number goes less than 5% in low and middle-income countries. But with regards to academic roles, again, the percentage is very small, less than 15% are senior academics are females. And why is there a need for change? So we know global health is weakened by the loss of females, ideas, talent, knowledge. Global women health leaders often expand the health agenda, strengthening health for all. And that gender disparity negatively impacts on health outcomes, both for women and children globally. If we achieve the gender leadership gap and narrow it, we know that this is a barrier to reaching the Sustainable Development Goals. So really important, particularly in low and middle income countries, to achieve universal health coverage. When you look at the geography of global leadership, so again, low middle income countries make up 83% of the population compared to 17% of the population. And it's all on the flip side. So despite having a much higher percentage of global population in the low middle income countries, the global health leaders are much smaller, 17% compared to 83%. And when you look at the percentage of females, this goes down even further, significantly further. So less than 5% of global health leaders are women in low middle income countries. So real significant differences and the need for change. When you look at the World Economic Forum Gender Equality Index, a lot of the South Asia, Middle Eastern countries rank the lowest, and Pakistan ranked the lowest a few years ago, and that's where some of our work has been concentrated in, and we've recently launched our pilot of Global Women Health Leaders program within Pakistan, but this is closely followed by many of the Middle Eastern countries, followed by Sub-Saharan Africa, and then in the high-income countries thereafter. In the UK, what's the position in the UK? So I'm based in the UK, and again, within the UK, we're far from perfect. Here, women make up, again, over 70% of the workforce, but only 37% holds senior executive roles, and 13%, less than 15%, hold senior academic roles. The gender balance at medical school is higher for females, but then as consultants, there's greater dropout rate as time goes on, and only a third of consultants are female compared to 54% of trainee doctors. And of those, only a quarter, less than 25%, hold trust medical director posts. So this gender equality is expanded further when you have other ethnic minority groups as well. So I'm from a Indo-Asian background. So women of Black, Asian minority ethnic groups are significantly underrepresented in leadership roles in the UK. So this number goes down significantly further. And why is this? Lots of different factors: social, cultural, organizational, personal challenges. And we know having a gender balanced and ethnically diverse population, which is much more representative of the population that we serve, helps improve patient outcomes. So that's the need, and that's the importance of what needs to be driven to drive the change as well. And we know that women at the top of organizations have been shown to change culture, improve organizational performance and patient-centered care. When we've looked at women health leaders and when we've done focus groups and different workshops, this is some of the output from some of the work that we've done so far. So many of the people would say that the barriers are the lack of role models, confidence, caring responsibilities, family commitments, cultural expectations. So a lot of this is beyond individual capability. A lot of our work has shown that individual capability is not an issue. It's the wider social cultural barriers which are causing a lot of these factors to come into play. And when you look at some of the published evidence as well, the barriers to women advancement are complex, but work-life balance is reported to be a challenge in up to a half of the women who've been interviewed. And this negatively affected childbearing decisions. Gender discrimination sadly still occurs, as well as unwelcome sexual advances in up to a third of people. And when you look at enablers, so what are the enablers? What are the things that help? So positive role modeling, encouragement, determination, that wider family, friend support, mentoring comes in, peer support networks, a supportive both home life, but also supportive in work as well, and accessible guidance, encouragement from mentors. So lots of different factors enable, and these are the things that we've tried to factor within our program that we're developing at the moment. So these are some of the barriers and enablers that I've summarized here. So work-life balance, gender discrimination, implicit bias, sexual harassment and assault, and then gender stereotypes compounded by the intersectionality, which I'll talk about in a minute. And the enablers, what helps implementing flexible working patterns, having that both encouragement, mentoring, positive support enables individuals to progress further. And intersectionality, so what is that? So it's an interplay of different factors which have an additive effect to these sort of particular issues. So I'm female of an ethnic background. I used to work less than full time. I'm British now, but my parents came from a different country. And then different factors. So all these factors have an additive effect in making the issue even more compounded and worse. And the important thing around this, when you think about the positives, is that if you know which are the factors, you can put in specific changes to address this as far as policies and practices are concerned to address some of these issues. So the Royal College of Physicians in London have been doing a lot of work in advancing women in leadership. We acknowledge that this is an issue, and we've been working on how to motivate and inspire women towards leadership goals. When we did our own work, the thematic analysis showed the key themes. So there's the practical difficulties, there's the social barriers, and there's the importance of building resilience through role modeling, mentorship, and support from others. This led to commissioning of one of our programs back in 2017 that I teach on, the Emerging Women Leaders program. And the emphasis of this program is to build leadership capability, capacity, and credibility in aspiring female doctors. And we also launched the Springboard to Leadership program, which focuses on inclusion, which is so important to inspire, support, and develop leaders from diverse backgrounds. So the Global Women Health Leaders is something that we've launched this year on International Women's Day in maps to our broader Royal College of Physicians vision, mission, and principles of providing the best health and healthcare for everyone, educating physicians to support and fulfill their potential. And by doing that, we will help influence and enable healthcare design and delivery to be improved, and healthcare prevention as well. And it meets a lot of our kind of wider work as well of promoting diversity of thinking, inclusion, and fostering local and national, international networks as well. So this scope of the program, we are focusing on low middle income countries because the gap there is the widest. We're focusing on early career stage and key transition points because that seems to be where a lot of the drop-off points come in as well. And we're hoping to provide mentoring and coaching to women to help develop their necessary skills, introductory sessions in leadership, emotional intelligence, and building in quality improvements so that they can take forwards their work within their own settings as well, and help improve networking opportunities, providing early career support as well, and continually assess the program and assure, and then hopefully, sort of roll it out further as well. So over the last 18 months or so, we've been working on this Global Women Health Leaders Programme. We talked about it on International Women's Day last year, in which we did a webinar across 4 continents of key women health leaders who'd made it over the years. And we talked about their barriers, their enablers, and what was important to drive their sort of success as well. And those are the things that we've then incorporated within our programme. When we subsequently did focus groups, initially these have been in Pakistan, both with stakeholders, key stakeholders, and then also with junior doctors and medical students. And some of the output has been shown here. Why Pakistan? Pakistan came lowest in the Gender Equality Index, World Economic Forum data, and hence we've started our pilot of our program there. So this focus group showed that although female ratio at medical school is very high, this goes down significantly in training position, and then in senior leadership positions, this goes down significantly further. And as I mentioned before, the individual capability of female doctors was less of an issue, is much more of the cultural barriers, the need for a huge shift in culture, both organizationally and socially, and needing that organizational buy-in with key metrics for organizational change. And what was supported was role modeling, mentoring with longer term programs, both locally and externally as well. And when we did our second focus group with students and trainees, again, there were issues around perception of capability and credibility. So although they were not less credible or less capable, it was felt that they were, and these issues of perception. And women were thought to be more emotional, seen as a red flag to working because of their work-life balance issues. There was much more bias and discrimination. And they felt that needing to instill these early leadership skills, negotiation, assertiveness would help them. That need for an inclusive organizational change and support as well, with clear policies on harassment, bullying, discrimination. And then that wider peer network support, role modeling, mentoring are key for gender-specific leadership skills to be developed. And needing to normalize compassionate leadership, that's something that I'm very much promoting. And certainly in low middle income countries, there's a need to normalize this. It should be normal. But anyway, that's what they felt was the need there. So around concepts of credibility, so credibility is the foundation of leadership. And a lot of our women in the healthcare workforce were saying that this is something that keeps being questioned. And if you want people to follow, they must believe that your words can be trusted, your knowledge and skills can be believed, and that you have that drive and determination to keep on, driving that positive change. And how do you build credibility? So the trust is an innate assumption, that's kind of something that you would base credibility upon. But then, as my mum always used to say, you need to earn that respect through the actions that you do and the behaviors that you're modeling. And over time, your knowledge and competence will be believed and your credibility will be encouraged and increased by that communication. And then when you look at the 5 C's of women health leadership, compassion, communication, courage, change, and compassion, all these things are hugely important. And that's the kind of things that we would definitely promote within the program that we're developing. And again, the importance of system change. So it's less about the individuals are less credible, less capable. It's how we can drive the system to enable the change to happen. So if you find yourself excluded, don't ask what's wrong with me. It's more what's wrong with the system and how does the system need to change to enable and drive that change forwards as well. So this is the program that we're developing at Royal College of Physicians, the Global Women Health Leaders Program, and we're doing it as a phased approach. So we're identifying and developing champions to begin with and senior doctors to facilitate that system change. So that's step one, develop the champions locally. Hopefully they will then take on board, they will be our buy-in, they will be our voice and advocate for the individuals going through the program. And then we would provide individual leadership development to individuals as well thereafter. And they would then cascade that development further. So like a train the trainer model as well. And the champions will be cascading the training, will provide networking opportunities and mentoring and wider support as well. And of course, we'll continually evaluate the program, tweak it, change it, adapt it for different regions as well, and then phase that out and roll that out based on feedback to other areas as well. So the proposed framework that I mentioned at the outset to narrow the gender leadership gap, we feel that we need a focus on the individual, the focus on identity, work on their lived experiences, tailor the program to local needs, cultural context, social context, and provide that wider mentoring and coaching support and positive role modeling. And then the organizational bit is really important. Understand the organizational structures of individual areas where we're working in, encourage and expand on that team working roles, developing the local champions to support the networks and support each other. And hopefully this will enable the system change as well, with greater buy-in from leaders and organizations that work within organizations as well to drive that cultural shift and enable system change. So in summary, the Royal College of Physicians Global Women Health Leaders Programme addresses an important gender equality issue. It's mapped to the broader Royal College of Physicians strategic aims. It's based on developing both individual and organisational leadership and promoting that system change to enable and empower women to advance into senior leadership positions. And hopefully this will help towards preserving female talent, ideas, knowledge, and reduce the gender leadership gap. And this will help improve health outcomes for women and children and hopefully achieve those sustainable development goals, which is so important, particularly in low middle income countries, and achieve universal health coverage. So thank you so much for listening. If you would like more information, please feel free to contact me on my email address that I put down here. I'd value your feedback and happy to take any questions. Thank you so very much.
Thank you so much, Dr. Patel, for sharing with us a very highly empowering program. And I wish you all the best in all your endeavors. Thank you so much.
Thank you so much, Dr. Amy.
You're welcome. Have a nice day, Doctor.